Trunda, are you there? Asmita? Hi, Trunda. I started the live streaming. You can go ahead.
So good afternoon to everybody. A warm welcome to all our participants and our speaker for the day, Dr. Rakesh Gupta, sir. So welcome to our Homeopathic Musings of 4th June 2022. Homeopathic Musings was started by Dr. Prajakta Vaidya and Dr. Preeti Shah during the lockdown. It's been almost 2 years and we are receiving an amazing response from our participants. Let me introduce you to our upcoming module, which is the basic course, Basics of Contemporary Homeopathy. This course is a course that is going to be a practical course both for the budding homeopaths as well as for the experienced and the well-flourished homeopaths. The topics that will be covered are the course that is being pathway by Dr. Shankaran, Dr. Sholton, Dr. Gandhi, and Dr. Yakir. We have 5 speakers who will be leading the program: Dr. Preeti Shah, Dr. Prajakta Vaidya, Dr. Reni Shah, Dr. Jyoti Udupi, and Dr. Chanda Shah. The course begins from 8th June and ends on 16th July. We look forward to your participation. So today's topic is bird's eye view on eye diseases and its homeopathic management. Our speaker for the day is Dr. Rakesh Gupta. I have immense pleasure in inviting Dr. Rakesh Gupta to lead our session for the day. I'm extremely excited as he has been a mentor and an inspiring person during our college life. He's done his homeopathy, MD in homeopathy, practice of medicine in 2008. He's done MBA, SCR. He's been a consultant homeopathic physician and expertise in treating hospitalized patients for the last 14 years. He has a private practice at Juhu Tara Road. He is also an associate professor and head of department of forensic medicine and toxicology in CMP Homeopathic Medical College. He is also an MUHS examiner in the subject of forensic medicine, appointed as LIC member in MUHS, appointed as subject expert for staff selection committee teacher of forensic medicine. He has worked in rural areas of Maharashtra with Dhavle Hospital for cataract detection and conducting awareness and alcohol de-addiction for the past 8 years. He has also been a major part of the management of tribal patients with various diseases. He has served as casualty medical officer and consultant in various departments at Dhavle Medical Hospital. Founder and president of Sattva Charitable Sanstha NGO. It's the first Sanstha NGO to receive permission from MCGM for free distribution for preventive homeopathic medicine against COVID-19. He's been a secretary Rotary Club of Addiction and Prevention. He has published various papers in national and international journal, example, dengue cases and its homeopathic management. He's been a speaker at various national and international seminars, and he has also conducted a webinar for the prestigious platform like Rotary Club of Mumbai Science. He specializes in geriatric health with homeopathy. He has also conducted various seminars like Health Aging for Senior Citizens for Rotary Club of Navi Mumbai. He's been a part of Rotary Club Navi Mumbai Sunrise, Linktown, Airoli, and also Rotary Club of D.Y. Patil School of Ayurveda. He has been felicitated as Corona Warrior during the distribution of Arsenic album during COVID-19. He is also an author in the e-book of Homeopathic in Ophthalmological Diseases. Thank you, sir, for accepting our invitation. We are honored to have you on our platform. Some basic hygiene factors to remember. Kindly mute your lines. Only chat questions at the comments at the end. We will take the questions at the end. Feel free to keep your videos on and make it an interactive session. And most importantly, enjoy our session. If you have any questions or difficulties, kindly contact the numbers that are on the screen. Over.
Hello, am I audible?
Yes, sir, you are audible.
I'll just share my screen. Is my screen visible?
Yes, sir.
Okay. So, good afternoon to all of you. And in India, it's afternoon. Other parts of the world would maybe a night or early morning. So today's session is all about eye diseases and ophthalmological disorders. So it's a very, very deep subject. So we will be just superficially going through certain interesting cases along with the applied anatomy, physiology, and pathophysiological understanding. So my journey in understanding ophthalmic diseases and eye diseases had started by facing certain questions during my residency, during my post graduation, and during my studentship. So basically, it was very difficult to do homeopathy in ophthalmic disorders. The reason was it's very difficult to convince patient that we can offer certain help with the help of homeopathy in these conditions. Many, if something happens to the eyes, it is always considered as an emergency. It is a do or die situation, and the person would always obviously want to see a eye specialist or an ophthalmologist. So these were certain factors which made the intervention with homeopathic medicine in ophthalmic disorder very minimum. So it was a very uncommon journey. When I started treating cases, so there were not a complete formal structuralized model or protocols where we could just pick up certain homeopathic drugs and we could give it. So it would be, some part was diagnostic, some part was understanding the individualizing symptoms of the patient. There were no enough observational experience available in the homeopathic world. There were few literature which was available, but any person was doing a full-fledged ophthalmic practice. There were rare situations where we could find a doctor completely practicing into eye diseases and homeopathy. And there were a lot of discouragement, which was because of, we had to go and learn from a modern medicine ophthalmologist. So there were a lot of questions that why you would like to learn this. If there is any kind of confusion, you can directly refer the patient to us. So as a matter of fact, what was important is to get more and more clinical experience that could be easily done when you go and attend government OPDs and work with government setups, because the number of patients coming there is a large number, and that would even help us to examine them and eventually learn from those patients. Attending camps were another source of learning, and the important thing was learning to diagnose. So majority of diseases related to eye requires a certain kind of specialized instrumentations for its diagnosis. So the certain important instruments which were helpful for the diagnosis were slit lamp, ophthalmoscope. So you have to learn direct as well as indirect ophthalmoscopy, keratometry, how to do a scan, and then how to interpret all these things. So these are various instruments which at least the basic operation needs to be understood while you need to diagnose, because the diagnosis is only possible by using these instruments. So that is what was the first thing which I had to grill myself, or I had to get exposed to all these instruments. So it's almost more than 16 years journey, right, in different role models as a student, as a residential medical officer, consultant, then becoming a consultant. So at different levels, different types of cases and different challenges, because uh, depending on the experience, you are able to take those cases. So I express my gratitude to my institutes where I learned these things. So my teachers, my colleagues, my ophthalmic partners, ophthalmologists and all. So they were the people who were always supportive. So let us begin understanding that eye, although it appears to be a small organ, its affections can be detrimental because major diseases of the eye often present with similar symptoms. The main symptoms are like pain, redness, swelling, decrease in the vision. So all these things are quite common in eye conditions. So eye can be affected or involved because of following reasons or following causes. Either it can be infective in origin, or it can be inflammatory in origin, as we say, autoimmune disorders like rheumatoid arthritis, SLE, or any other ulcerative colitis. They may also present as an eye as a presentation. Then injuries, any form of injuries can also result into an eye involvement, and then eventually the patient presents with eye signs and symptoms, or congenital in origin. So these bifurcation needs to be understood. Different parts of the eye has a different type of symptomatology or presentation. So each tissue in the eye will have a different peculiar symptomatology. One symptom which will be much more intense, one symptom will be much more higher in intensity compared to other symptoms. Like there will be an watering of the eye and light sensitivity, photophobia, which will be there in some amount of photophobia is there in conjunctivitis. Some amount of photophobia will be there in uveitis, or the inflammation of the iris, and some amount of photophobia will be there in the involvement of the cornea. So if the cornea is involved, the intensity of photophobia will be much higher in comparison to conjunctivitis, or it will be much higher compared to a iritis. Many a time certain symptoms, the group of symptoms which may arise will have multiple differential diagnosis. A person may have pain, lacrimation, redness. So often, if we, as a basic concept, we'll say that it is a conjunctivitis, but we have to be very careful that if the photophobia is much higher in intensity, then instead of conjunctivitis, we have to look even onto the cornea, because the cornea inflammations can be examined through slit lamp examination, and we'll come to know it only after doing a slit lamp examination. There may be a possibility that patient initially had a conjunctivitis and now the inflammation or the infection is traveled to the cornea. Another important thing is more superficial tissue involvement, more chances of its reversibility, except in cases which are mainly congenital in origin, or mainly malignant disorders. So these disorders, the chances of reversibility reduces. Like example, conjunctival problem like coloboma, or these conditions will be much more difficult to treat with the lesser chances of reversibility compared to a deep-seated disorder like iritis or uveitis. So the tissue is one factor, that superficial tissue responds better, but there are certain disorders where the etiology is irreversible, like cancer or the congenital abnormalities, where even if it is on the superficial level, then the reversibility chances will reduce. So let us classify according to the tissue involvement. The simple way which I used to understand it is Let us classify according to the tissue involved. First is lids and the conjunctiva. Second, cornea. Third, lens and capsule. Sclera, uveal tract or the ciliary body, choroid, macula, and the retina. So these are the various tissues which we eventually see during the examination and while we are studying the anatomy. Now, classification based on the nature of the insult, nature of the problem. Like example, it is because of injury, or it is because of any kind of autoimmune inflammation, or it is because of infection, or it is because of malignancy, or it is because of congenital origin, or there are certain disorders which are senile in origin or senile diseases. So the concept of treating these disorders are based on basically a knowledge of disease. As so the anatomy and the physiology knowledge is very important, and understanding the pathophysiological changes which will develop eventually when the disease progresses. What are the different stages which would be seen in this particular disorder? And for diagnosing these changes, we need to understand how do we use the equipments or the diagnostic tools or techniques in order to pick up the right diagnosis. So it's like, doing a clinical examination is very, very, very important, because there are certain symptoms or certain objective signs which can only be picked up, when we are doing a clinical examination. And especially when we talk about the modalities, like if you want to check for the photosensitivity or a photophobia, till the time you don't put a torchlight into the eye, you will not understand the intensity of photophobia. So there are certain remedies which has got intense photophobia compared to other remedies. If you can see, it's like a globe. You have a camera shutter. The camera shutter which closes and opens is nothing but it's a pupil, and pupil is circumferentially because of the iris. It's an iris, and the glassy portion which you can see, the glassy portion, or it is like a windscreen of a car, is nothing but it's a cornea. So cornea is one structure which is completely transparent. So imagine if there is a fog over the window glass, you won't be able to see the exterior part of the world, right? So similarly, if there is a cornea which is hazy because of XYZ reason, whether it is inflammation, whether it is infection, whether it is injury, if it becomes hazy or opaque, then the exterior part or the light which is coming from the outside world and entering our eye will not be able to pass. And if it doesn't pass and falls on the retina, you won't be able to see. So that's why cornea has to be preserved. That's why we have to be very careful. There should not be any kind of injury or any kind of insult onto the cornea. This is the cornea. This is the iris, which is circumferential. This is a cut section. It's a sagittal section. Okay, this is the iris, and this is the lens. So lens is like how we have a lens, magnifying lens. Similarly, your body has a lens. The eye has a lens. The light passes through the lens and then it gets refracted and it falls on the different part of the retina, which is a photosensitive tissue. It is rich in rods and cones. So these are pigments. Rods and cones are pigments, and eventually the signals are carried through the optic nerve, through the optic pathway, and it reaches the brain, and you are able to interpret, okay, this is a face of a so-called speaker, today's speaker, Dr. Rakesh Gupta. So this is how you are able to relay it throughout the optic path, and it goes and forms an image on the occipital lobe of, that is the visual cortex. So this is how the things happen. So anything which is anterior to iris is known as the anterior to the lens is known as the anterior chamber. And if there is an iris and the inner surface of the cornea, that is known as the anterior chamber, or this is known as the AC, anterior chamber of the eye. Anterior chamber of the eye. And here is the place where the aqueous humor is present. Aqueous humor is present. Aqueous humor is a fluid which is being formed in the ciliary body there, and it gets collected here for some time, then it is drained, and again the new aqueous humor comes. The role of aqueous humor is to basically maintain the integrity of the cornea and give nourishment to the cornea, because cornea doesn't have any blood supply on its surface. So in order to keep the cornea alive, it requires nutrition which is passed by the aqueous humor, and the cornea remains healthy. If the aqueous humor is not there, then the cornea will not remain healthy. Cornea will become hazy. So this is a function of the aqueous humor. And similarly, we have retina. The most central part of the retina is the macula. Now we are looking at each other. Okay, you can see my face, I can see your face, right? If we are doing that. So the portion through which I am looking at you is the central part of the retina. So macula is always responsible for the central vision. So if I am looking at someone's face and I am able to identify it, that's mainly because I have my normal macula. Moment we have a problem with the macula, you won't be able to see the face. Other than the face, other peripheral things you will be able to see other than the face. So you won't be able to see the face of the person, but the peripheral vision will be intact. So you see periphery. So this is what the macula is. It is responsible for the central vision. And if you are not able to see that center part and you see the periphery, that is known as central scotoma. Scotoma. That means a black spot in the field of vision. That's known as scotoma. As I've already mentioned, that eye is like a globe which is made of a membrane. So there is sclera. You can see in this, there is an optic nerve, the nerve which carries all the sensory input. Different parts of the eye will carry the signal, different parts of the retina, and it goes through a narrow nerve sheath that's known as the optic nerve. Here I had mentioned that anterior chamber has aqueous humor, which gives the integrity to the anterior chamber. Similarly, the posterior chamber has got vitreous fluid, that's known as vitreous body. Okay, so that's important. It's like a jelly-like substance which gives a shape like a globe to the eye, and it also provides its nourishment to the innermost surfaces of the retina. So now we slowly move from the anatomy, and how do we use the anatomy while we are handling cases. That's very important. Now I will tell you the cut section of the cornea. So anterior part of the membrane is transparent, I have already mentioned, and that is termed as cornea. Cornea is like a watch glass, which is it is just fitted over the other part, white portion which you see in my eyes. That white color thing is nothing but it's a sclera, and the transparent through which the eye rays are entering is the cornea, and this cornea is just kept like a watch glass over this neighboring membrane of sclera. You can see it's a watch glass, and this is the sclera. So now, if you understand the cornea, why the cornea is transparent, it is mainly because of the stroma, which is one of the layer of the cornea. This is the reason why the cornea is transparent. And if this stroma, which is, you can see in this diagram, the outermost portion is epithelium. Below the epithelium, there is Bowman's layer, and this stroma. This is a stroma which gives a transparency to the cornea. So if any infection, any injury, or any inflammation, it enters this layer, then the transparency of the of the cornea will be lost. So now why we are trying to discuss this is the reason is the patient many a times comes and asks, okay, now I've got this kind of a opacity. Maybe I in the childhood I was not aware. I developed herpes zoster, infection which involves the nerve, especially the if it is over the face, it is because there was an involvement of trigeminal nerve, and now the ophthalmic division of the trigeminal nerve also got involved, and the eye became red, inflamed, swollen, lacrimation, and then eventually there is opacity. So they will ask you whether we can treat this. So this has to be understood that the person has the stroma has got involved. Then that is the reason why this person has developed corneal opacity. So chances of reversibility will also reduce depending on the how much portion of the stroma which has got involved. If it's the entire length of the stroma, then it is a very difficult thing to be cured. In modern medicine, from an ophthalmic point of view, they often advise corneal grafting. They give a corneal graft and tell this can be this is the only line of treatment which is available. So I had already mentioned that it's a transparent glass, so it doesn't have a vascular supply. Cornea gets its nutrition from the vessels which are at the sclerocorneal junction, and through the aqueous humor, which is in touch with the endothelium of the cornea. Endothelium is the innermost. The outermost was epithelium. The innermost of the cornea, which is inside the eye, is endothelium. So this is the sclerocorneal junction. Here the cornea ends, and here this is the sclera which is starting. Here the cornea ends, and from above, so here there are vessels which will, through like an arcade, it will supply the entire circumference of the cornea. And the aqueous humor which is there below will supply the cornea from inner side. So now this is an example of corneal opacity, which is so now when we are trying to understand from a staging of the disease and homeopathic angle, we often understand whether it is a reversible disease, irreversible, whether it is functional or structural. So it is a structural irreversibility zone which is seen in this particular. So any kind of injury, inflammation often results into post-inflammatory scarring, which is known as fibrosis, and the density of this opacity depends on the depth of the inflammation, injury, or infection. So many a time it is considered as one of the permanent damage. Again, the concept of reversibility and irreversibility, which we were trying to discuss. So now I'll start with one of the case of corneal foreign body injury. So I had a patient which had presented with red eye, pain, and all the other symptoms of like foreign body sensation is there. There's something stuck in the eye. So this was, then what we do is we can't see with the naked eye. Okay, what is the problem? So what you do? We do a fluorescent staining. Fluorescent staining was done. Fluorescent staining. There are strips which are available. They are known as fluorescent staining strips. You put it in, invert the eyelid, and you put it down, and then just close the eye. The eye will take up the tear film will take up the entire stain all over the. So usually the normal corneal epithelium will not have a staining. So whenever you get a staining, see, like in this particular case, it means there is an abrasion or there is a denudation of the epithelium of the cornea. So wherever there is break in the continuity of the cornea, that point precisely the fluorescent stain will take. You can see here. This is at around 5 o'clock position. If you divide the eye into clockwise, then it is around 5 o'clock position you can find. So there is staining which is seen, and there is some minute black color portion which is there in the center. So you need to go in detail. So this is nothing but a foreign body injury. The person was a stone cutter. They usually polish the stone and cut the stone and give the shape to the stone. A small piece had entered the eye, and thereafter all these things had started. The patient had presented with pain, lacrimation, and photophobia. So now when we are trying to treat this patient, what we have to understand is first the maintaining cause has to come out. There will be of no use giving them the medicine, whether it is eye drops or whether you're giving homeopathic medicines. This will not help until and unless the foreign body is removed. So you have to remove the foreign body, and secondary inflammatory changes which has set in because of this foreign body has to be managed with the help of the proper indicated medicine. So what we do is they classify the disease before we start the treatment. We have to understand that it's a surgical disease with one-sided expression, one-sided because it is only pertaining to the eye. And because of this, there is a secondary dynamic affection. The person has started developing the symptoms, which is the eye pain, redness, swelling, and sometimes patients may present with headaches and all. So when you take this rubrics, eye injuries from incision or eye injuries from laceration, these rubrics in the repertorization in radar, this repertory, you find there are certain remedies, which is like aconite silica, staphylos aureus, Acerem hypericum, and staphylos aureus. So when you read these remedies from Materia Medica, what we understand is Acerem is also a remedy which is basically involving the injury component is one factor. Apart from that, there is a lot of neuralgias and pains which are there in Acerem. Acerem europeanum. The most important characteristic symptom for Acerem europeanum is patient is better after bathing the particular part, or the particular part is better after cold bathing or cold water washing. So that is what is there in Acerem. Hypericum is again inflammation injury which eventually leads to inflammation of the nerve. So there are again a lot of neuralgic pain, sticking type of pain, and it is predominantly in Materia. It is more on right sided, but in actual practice, the injury can be either right or left sided. So it is nothing to do with the side affinity. Then this is what is seen in hypericum. When we see staphylos aureus from the Borix Materia Medica, it is clearly written that there is a laceration of the cornea with the prolapse of the iris. So the laceration is of that intensity that the iris may prolapse and it can come out through the eye. You will see that iris is protruding through the aperture in the cornea, and it is mainly also indicated in cases where there is post-operative complications, especially while performing the cataract surgery. And also it is with these injuries and inflammatory changes may also happen in the iris, where you find there's a lot of bursting pain in the eyeball, temple, and the sides of the eye. And very important symptom is there is severe photophobia, which is seen in these cases. So we started with staphylos aureus, which was given every 1 hourly, and eventually over a period of 12 to 14 hours, patient was completely asymptomatic. And before that, we had to remove the foreign body, and this is how it looked after removal of the foreign body. And when we took a photograph on the slit lamp, this particular thing, you can see this particular central portion. So there where we remove the foreign body removal. So first is the removal of the foreign body or any obstructive pathology, eventually treating the patient. The patient's eye was completely normal. The inflammatory changes had settled down because we started him on staphylos aureus. I had also mentioned earlier that cornea is the most sensitive part of the eye because of its there is no vascular innervation directly in the cornea, but there is high nerve innervation which is seen. and that is the reason why patient gets intense photophobia. So the moment you find patient is having severe photophobia, always suspect that there is a corneal involvement, whether it is to begin with a conjunctiva, but later on the disease can progress to the cornea as the tissue. Many a times I've seen that, you know, patients were treated by at the local level because I was running an ophthalmic OPD at the rural areas. They were primarily treated as, you know, kuch nahi hai, conjunctivitis is going on, and eventually later on when disease progressed, it was not conjunctivitis but it was keratitis. So I share with you another case, which is an ophthalmic emergency. One of the important case which taught me a lot. It's a case of a corneal laceration with hypopion, with iritis, with posterior synechiae, with pupillary capture and complicated cataract. There are multiple diagnoses because these diagnoses suggest that, you know, it started with one tissue of the eye, but eventually the disease progressed deeper and deeper, and it involved multiple tissues or multiple organs. There is a multiple parts of the eye. So this was how the patient had presented. This was the edematous eye. Both the lids were closed. It was cellulitis around the orbit, and it was a congested eye with lot of watering, and patient was not able to see at all. So it's a case of a 45 years old fisherman who had reported to me and the casualty and he had come with a history of injury due to the left eye because of the iron wire while fishing. So it was 2 weeks old injury when he reported to us. He complained of lot of redness, lacrimation, swelling, pain, and visual loss. He could not see anything from that eye, and it had started after the injury with an iron wire. While they are fishing, they use a net which is made up of the iron wire, and while he was throwing that, one of the side portion of the wire had just hit him, and it led to an injury to the eye. Now later on we'll come to which part of the eye got injured, but patients understanding that it got injury, it led to an injury to the eye, and it had injured the eye, and because of which he is not able to open his eye. He cannot bear the light in the environment, and this pain is of a higher intensity, and it is of a stitching type, and there is slightest of light is worsening the pain. Cold air, he can't tolerate the cold air, and he's better by warmth. That is how the presentation was. Clinically, when we see, it is both lid edema, congestion, lacrimation, photophobia, and there is something called as PR and PL. When the person is not able to move, open the eye, he is not able to see anything. He is not able to read because of the inflammation, because of the redness, because of the edema, because of the swelling. So the only thing in the doubt is whether the retina of that particular eye is intact or damaged. So in order to understand whether the retina is intact or damaged, you do a PR and PL. PR means projection of ray and projection of light. PR is projection of ray, PL is projection of light. So when you are taking a torch and you're shining the torch over that particular eye, what you are, and by closing the other eye, you ask him whether he is able to see something. So he says, okay, I am able to feel the light. Then you ask him from which direction the light is coming. So you try to rotate the torch and keep it in different direction, and you ask him whether it is coming from the upper quadrant, right lower quadrant, left lower quadrant, left upper quadrant, right upper quadrant. So you ask him from where the light is coming. So if he is able to correctly interpret or tell us, or he is able to see this thing understand this thing very clearly, that means there is PL. He is able to identify the light, perception of light is present, and plus he is having perception to rays also, which direction is the rays coming up. Now you see, with the help of with the assistant, we were able to open his eye, you can see this is the cornea, and you see this portion down, this white portion. I will just let you know after this slide what it is. So this is how, and you can see there is a redness, complete redness. There's a edema. This is macroscopically. Then we start using a slit lamp, and what we saw here is at this section, you see this is a cut. This is an injury. This is a laceration on the cornea. This is a laceration on the cornea. You can see here. There is a iris which is looking very, 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 very muddy, very muddy. Muddy iris means it is inflamed iris. It looks as if there is a mud. It looks, mud is brownish. It looks more brownish. And if you can see, there is small pigments. These pigments are mainly because the iris was very, very inflamed. Because of this inflammation, the iris was very fragile, and some part of the iris, some parts of the iris got stuck onto the lens. And you can see this lower portion. You can see this lower portion, this whitish. It is nothing but it is a pus in the anterior chamber. So there was an injury, introduction of the inflammation, introduction of the infection. There is a pus formation, and you found that there is a complete inflammation of the iris, which is now started shedding small pigments all over the lens. And this iris portion is got stuck onto the lens. It is so sticky and fragile that it goes and gets stuck all over the lens. You can see this. So iris, so then that means iris is supposed to have a pupillary action. When there is exposure to light, the pupils constrict, and when there is exposure to dark area, then there is a dilatation of the pupil. That particular function is lost, because of which the reason behind this is the iris is got stuck onto the lens, which is posterior to the iris. So that is what is known as posterior synecdoche. So this is a finding. Muddy iris is nothing but it is the inflammation of the iris. It looks very, 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 very inflamed, and it looks as if it's like a mud. And there is an irregular pupil, and there is a posterior synecdoche, means the iris has got stuck onto the lens. That is known as posterior synecdoche. And there is a pus in the anterior chamber, that is known as hypopyon. And this is a better view. If you can see how the iris is stuck. So now in examination, during examination, what we found is there is a circumcorneal congestion, means the entire cornea, surrounding of the cornea is inflamed. There is severe photophobia because the person is not able to open the eye. There is a corneal laceration at 8 o'clock position, which was seen in that particular photograph. There is a pus in the anterior chamber, and the pupils are not reacting to light. There is a posterior synecdoche, and there is a iris pigments. So now, understanding the anatomy is very important. I have already explained major part of the anatomy, and because if you understand anatomy, we can understand the disease better. I had already mentioned about the cornea and it is transparency, and it basically function is to allow the light to enter and just fall onto the lens. So that is the main function of the cornea. So if there is any change in the curvature of the cornea or injury to the outer layers of the cornea, it may lead to a distortion of the image, or there is sometimes it is known as astigmatism also. So injury, which has now in this particular case, it has disturbed the protective layer of the eye. It has disrupted the barrier. It is a protective layer. It has disrupted the barrier. And there is an infection which is introduced into the eye. Mostly these infections are very resistant infections, and many a times it is found that the fungal infection happens. So it becomes more difficult to treat the person, because majority of the time these patients have been prescribed a combination of antibiotic and a steroid, so which will not help the patient. So he had already visited ophthalmologist, and he was taking all these medicines for almost a 2 weeks period, but he was not getting better. So Now seeing this, we are not able to see anything because there is a cataract which has developed, complicated cataract. We are not able to see beyond the lens what is happened to the retina. So it is always important when we take up this case, we should understand whether the retina is intact or it is damaged. Why am I saying so? Even if you treat the infection and after some time you come to know that infection is been treated and there is a injury to the retina also at the same time, so then you cannot promise the qualitative result to the patient. You have to tell that what is the possibility of reversibility before we start the treatment. We cannot just say now if the person cannot get the vision back even after treating patient for 2 months 3 months. So you have to be very careful what is the state of retina right at the start of the treatment. We cannot just reveal it later on. So for that, we do a USG B scan where we understand how is the retina. It's a form of sonography, B scan. It is a special sonography of the eye and you do a scanning of the retina. There is no evidence of retinal detachment. And what we do is we also check the pressure because of the injury and infection and inflammation. Many a times the eye pressure will also be more. So in this particular patient, since the injury was onto the left eye, now the right eye is 13.6 and 14, left eye is 14.2. So anywhere if the pressure is reaching 20 and above, then it is, increase in intraocular pressure and it may be called as glaucoma. So this was a diagnosis. I think now it is you are in a better state to understand. All of you are a better state to understand what is the diagnosis in this case. And lastly, I had mentioned that there is a complicated cataract also. Cataract is nothing but it's a opacification of the lens. The lens has got opacified. So the ophthalmologist, what ophthalmologist would suggest in this situation is he will say, let us give a subconjunctival injections of some antibiotics so that the pus can be dried up, or he may do paracentesis. Paracentesis is nothing but they go into an anterior chamber and they actually irrigate or wash out the pus from that chamber. And next is you have to keep the iris dilated or pupil dilated. In order to do that, you put a atropine. Atropinization in order, because that will, if the pupils are dilated, that will reduce the pain to the patient. The amount of pain which the patient is experiencing, that will get reduced. Now, in comparison to this, what a homeopathic doctor can offer. Now you understand it's an ophthalmic emergency. It has been already it has been seen by an ophthalmologist. He has been given these particular types of treatment and then he is coming to us. So now here we have to understand what we can offer. So before that, we have to understand from a homeopathic conceptualization point of view, there is a trauma, there is an injury, there is an infection, there is a suppuration, there is an inflammation, and inflammation is involving the iris, and there is, because of which there is a complication in the cataract formation, and all these things collectively has led to the loss of vision. This is what we have understood in simple words. So now we classify homeopathically. It's an acute onset. It is a local pertaining to a local organ, surgical in origin. Initially, it is a non-miasmatic disease, but eventually there is a secondary dynamic miasmatic expression which develops. So initially, to begin with, it is non-miasmatic, and eventually the inflammatory process starts, and it has a expression which is going into a miasmatic and a fully expression of the symptoms, the fully development of the symptoms. The symptoms have developed. So it is structurally irreversible. If the pus formation increase, and then it will block the entire angle of the anterior chamber, and which may lead to increase in the intraocular pressure and leading to glaucoma. And many a time infection, if it is not tackled, it may spread to other tissues also, something which is known as panophthalmitis. Panophthalmitis means that all the tissues of the cornea, including the cornea, iris, uvea, choroid, sclera, retina, everything is got involved and infected, and it's a stage which is very difficult, and many a time the infection, if it is more, then it may lead to phthisis bulbi. The eye will start shrinking in size. There will be pus formation, and eventually the complete eye is destroyed. I had mentioned about IOP, raised IOP, intraocular pressure, that is seen in glaucoma, because if this angle gets blocked because of the pus is thick in nature. So this thick debris may go and stuck into the angle through which the aqueous humor is getting drained. Then what will happen is there will be oversaturation, overfilling of the aqueous humor in the anterior chamber, and patient will have complaint of rise in the intraocular pressure. So this is, if there is a rise in intraocular pressure, what you see is the optic disc and the cup ratio will also change. There is an optic disc and there is a widening of the cup, which is classically seen in glaucoma, which is suggestive that the optic nerve is dying. Optic nerve is dying. So that is known as optic atrophy, which is developing. So from our point of view, what are we going to do is, first we will give some homeopathic medicine. That's a homeopathic medicinal line of treatment. The objective is to treat the infection, clear the pus, to reduce the inflammatory signs, and completely quieten the eye and the infection. And the second step should be to remove that complicated cataract with the surgical mean and put a lens, so that the media is clear, the light entry is allowed. So first thing is the medicinal line of treatment, which is very important to be understood, so that there is no sign of any infection and inflammation in the eye. So that is our objective. If there is an inflammation and the infection in the eye, we had it. We cannot go on the next step. Here we have to understand that cataract which is developed is a complicated cataract because of the quantum of the infection and inflammation which resulted into the eye, and that will block the vision. So what we should not think that okay, we will also target a cataract and we will cure it. First target is to completely annihilate the infection. Second target is to remove this cataract so that the vision is given back to the patient. So we have to understand what is to be cured in that particular disease and how it is to be cured. The line of management, if you understand, is the cause is injury and the manifestation is suppuration, and everything is very sudden, which has happened, and we have certain modalities. So if you formulate the totality, what we have to understand is eye injury from eye inflammation, iris hypopyon with eye pain, which is worse by cold draft air and better by warm application, and eye pain stitching. So if you repertorize this, the group of remedies which are coming up is HIPAA, silica, thuja, spigelia, aconite, sulfur, and nitric acid. So these are the medicines which are coming up. At the same time, we also understood his constitutional history. It was found that he is a mild person, doesn't retaliate even during the fight. And in order to settle the score, wife has to intervene. For him, work is very important, and he continues to work even when he has got this problem. So he is very workaholic or industrious. Then what we found that he is chilly, and winters it is found that he has got cracks in his heel. This is the acute presentation which was found, that the injury, cold air, better by warmth, pain, stitching, hypopyon. This is the acute presentation. And this is what we have understood, that it's an over-exaggerated response of the body. And miasmatically, if you understand, it is a heightened, exaggerated response. So we understand it as a tubercular response post-injury. And chronic constitutional totality is this. This is the acute totality. So many a time in a particular disease, the acute presentation is one part. And when we are trying to deal the patient, take care of the patient, and we are trying to understand the patient, we also find out the other constitutional data, which is very important. So now the problem is which line of treatment we should give. To directly start the acute, because we have got history at both these sides. The chronic history is also there, and the acute manifestation history is also there. So acute phasic remedies which were coming up was Hepar silica, and sulfur. And the chronic constitutional remedy which is coming up was silica. So now if we understand the remedy differentiation, we have to differentiate between Hepar, silica, sulfur, spigelia. If we go ahead, we understand disease as a dynamic phenomena in nature, proceeding from the phase of normalcy. If there is a normalcy, then it goes to diathesis, to the phase of disease. And when the disease starts from the prodrome, functional, and the structural. So what we have to understand is understanding the pathogenesis. Maybe the injury is there in arnica, maybe the injury is there in symphytum, maybe the injury is in silica, there may be an injury in staphysagria, or there is an injury in spigelia. But how the pathogenesis evolves, that is what is very important. So cause may be there in multiple drugs, but the disease effect or the progression and the evolution and the changing totality is which matters a lot. So this is what we have to understand. So considering this, we were differentiating between Hepar, sulf, and silica to begin with from various materia medica books. Both has got injury, both has suppuration, inflammation, and pus formation. But the way in which the disease progresses is different in both Hepar and silica. If I was reading Boger is beautiful book which gives us the pathology and pathogenesis. Boger teaches us about the tissue affinity, how the tissues they react to a particular disease. So in Hepar sulf, it was found that it's a quick suppuration and a very, very hypersensitive response. In silica, the suppurations are very torment, slow, and it is very, very indolent and impending or incomplete. So silica is often indicated where there is a suppuration which has started but is never ending. It is going for months, years, maybe days. It is not even terminating. Neither it is it completely resolving. In a right sense. So it is found that in Hepar sulf, the pace of disease is very quick, rapid, and violent. In silica, it is torpidity, slowness, delayed, stubbornness, and incomplete processes. That is what is seen. And the same thing is seen at the level of mind also. The body and mind, many a times they are go in congruence with each other. And if you understand the Hepar sulf, it is the hasty, violent, irritable, and dissatisfied person. And it is very sensitive and touchy. Touchy in the sense, slightest amount of remarks, slightest amount of reprimands, slightest amount of a comment will affect that person violently and the person will react. Whereas silica is a very tolerant and enduring guy or enduring person. There's a lot of endurance. There is lot of calmness, lot of torpidity. They do not violently react until and unless it goes out of proportion. It goes out of proportion. They have the tendency to what we say, tendency to tolerate things. So basically in Hepar, it's a touch me not phenomena and a hypersensitiveness which is found. In Hepar, the cornea is the seat of disease, as well as in silica, the same is also true. Hepar is known for its ulceration and inflammation. Silica is known for opacification. Silica will have a lot of deposition and opacification and cicatrices which form. Cicatrices or fibrotic tissue formation is more common in silica. So that's why when we are actually treating cases, especially with tuberculosis and all, there is a caution that don't repeat silica or don't use silica until unless you are very sure. Don't give it repeatedly and all until unless you are very sure. It should not produce the breaking of the old fibrotic scars of tuberculosis. If these fibrosis start resolving, there may be an activation of COX. Both have got common modalities of cold aggravation and relief by warmth. HEPA self has got involvement of the cornea as well as the anterior chamber. Silica has more affinity of lacrimal duct apparatus, and then there is a formation of lacrimal fistulae or dacryocystitis. Dacryocystitis is nothing. It is an infection or inflammation which is involving the lacrimal apparatus or nasolacrimal duct. Nasal lacrimal duct gets inflamed and infected and leads to a pus formation. This is very self-explanatory. HEPA is predominantly tubercular and silica is psychotubercular. And this was about two drugs, HEPA and silica, which was coming very closely. Spigelia is another drug which is mainly used for neuralgias. Any neuralgias involving the cornea, iris, or the sclera, there is a deep inflammation. So patients with scleritis, you can use spigelia. Very commonly we find there is a deep socket pain which is there, and the spigelia is a good drug which covers the neuralgias. There is a pain in eye, deep socket pains, and it's sore, bruised, and radiating pains. There is a neuralgia which is not only involving the eye, but it will start involving the face and the head also, and there is high sensitivity to touch. Whereas in sulfur, it is predominantly involves the superficial tissues of the eye. It has predominantly involvement of the eyelashes or the conjunctiva. There will be falling of the eyelashes, or there will be blepharitis. Blepharitis is nothing but it is the inflammation of the eyelids, and the patient will say that there is a itching of the eye. So itching is a very predominant symptom which is seen and there is a burning pain, as we all know. This is also relieved by cold application, and there will be a lot of photophobia, which is mainly conjunctival in origin. So
Sir, you are on mute. So please unmute yourself.
yeah, now it is unmuted. I think the host had muted me.
Yes, sir.
So again, complementary remedy relationship is understood. It is very important to understand there may be two drugs which may be complementary to each other, may be indicated in a case, but if you don't use the right drug during that particular phase, which is the indicated phase, then afterwards if you use it won't help. So you cannot go out of the phase and use that particular drug. So if suppose a bryonia is indicated, you use bryonia instead of using a kalika. So these signs of indications would be through signs and symptoms or the modalities or whatever the pathology is. So if you understand in this case, according to me, HEPA was better indicated remedy in comparison to silica. The reason is the causation, which is there common, although common in both. But if you understand the pace at which the disease had involved, it has involved in a way where the disease is kept on progressing. The cornea, then there is an infection, then it has involved the iris, then it has gone and involved the lens, and if you would have delayed, probably it would have gone into the posterior chamber of of the eye also. So the pace, the speed, the pace of the disease is very important. So if you understand the pace has to be understood. Like example, if a patient comes with a fulminant vaginitis or leukorrhea, then you may give pulsatilla. But if the pace is and it is very accurate, and it is very deep infection, maybe almost going like an PID, pelvic inflammatory disease, then the creosote will be much more indicated. So you have to identify the pace. Many a times it looks very similar, but if you understand the pace and the depth of the inflammation and the infection, that will identify the right indicated remedy. So here I had started with HIPAR, initially 200, then 1M, and it was given repeatedly over a period of, initially maybe 200 was started with 2 hourly, and eventually 1M every 4 hourly was given. The duration of this medicine, see, I am giving a summarized follow-up. I had evaluated the person every week, so but I'm not putting all the follow-ups there. So over a period of almost 1.5 months, over a period of one month and 20 days of then it is seen that the pain, swelling, lacrimation, redness, pus, photophobia, everything disappeared. Cataract and the posterior synechiae were still there, but they are the sequelae. That means the storm has come and gone, but the damage will remain. So the cataract and the posterior synechiae are the sequelae of the infection and inflammation, which will need to be corrected with surgical line of treatment. But if the pus has disappeared or the photophobia is disappeared, then hypopyon is disappeared. That means our remedy is in the right direction. So if we can see, the hypopyon is completely disappeared. And if you see the iris is now, this is how the iris looks. If you throw a light on this, this is how the iris looks. Here the previous iris was looking very muddy iris. Here is the posterior synechiae. Here you can see it looks normal iris. This was a person with an inflamed eye, unable to open his eye, photophobia, swelling, lid, edema, and lacrimation. Here is the person after the treatment, only the cataract which is seen. Acute remedies are selected based on the presentation and the pace. And many a times these remedies are important to cover the superficial or tide over the acute violent phase of the disease, and which are sudden in origin, violent in origin, and highly intense. So these remedies needs to be followed with a chronic remedy. Yes, this needs to be followed with a chronic remedy. In our case, silica was coming as a constitutional remedy. So now we gave a deep acting drug which can sustain the effect, and there should not be any kind of a minutest amount of inflammation and infection in the eye. So silica 30 potency was used, and it was given a single dose every week for 5 weeks. So now what is important is, before we move on from the step 1 to step 2, step 1 is a medical line of treatment, which is primarily with homeopathy, without any antibiotics, without any steroids, without any topical eye drops, without any topical ointment. And eventually we are shifting the patient from a step 1 by cleaning all the infection and inflammation and quietening the eye. Quietening of the eye means the eye is free of all the inflammation and infection, and then we are trying to shift the patient on the step 2, which is a surgical line of treatment. Before that, we have to be very sure, because if there is slightest amount of infection in the eye, and if you do an operative procedure on such an eye, there is an invitation of a problem where you will try to push the person into a fulminant phase, and entire layer of the eyes, forget about the cornea or the iris, the entire layers of the eye will go into a sudden inflammation that's known as panophthalmitis, and the person will lose the eyesight for lifetime. So that is what is very important. So before that, we have to be very sure. And I was in touch with an ophthalmologist, and he was evaluating this case right from the day 1, and he said that this is the this is the point. Now the person is completely free from inflammatory process. Now we can take the person on the second step of the this second stage or second step, and this is how the cataract was removed and there was no pus. And the iridectomy was done. The posterior synechiae, in order to remove the cataract, the iris has to be cut so that they can reach the cataract. So they can reach the lens, so that they can open the lens and remove the opacified lens. They have to open the lens bag. They will open the lens bag and they will deliver out the opacified lens, and they'll put the new lens in that. This is how the person looked after the cataract operation. And then what we found is his vision was 6/6 in the eye, which has gone through so much of inflammatory process, that the eye was quietened and it was operated and the vision was 6/6. So this was a case which was a very, 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 high pressure. We were all, the entire team was into a very high pressure zone, because we had to see to it that, this person gets his eyesight back. And another important thing, very important thing is, pre-operatively, no antibiotics were given to this patient. No antibiotics were given to the patient. He was completely, because ophthalmologist very sure that if the pus has disappeared without doing any surgical intervention, without any wash in the anterior chamber, so we don't need to prescribe antibiotic. Your medicines are correct. You are in the right direction, and I will operate this eye without any pre-operative antibiotic coverage. So this is how we got a response from our ophthalmologist, who was very, very happy with the homeopathic line of treatment. Now, after you finish the cornea and we have discussed this, I'll show a case related to a lacrimal duct infection or the lacrimal apparatus. At the upper outer part of the upper outer part of the eye, we have got a lacrimal gland. And this lacrimal gland is actually producing the tear. Tear is like, it's like a tear is rich in immunoglobulin. It is rich as a lubricant, which lubricates the outer portion of the cornea, so it doesn't allow the cornea to dry up. And these tears are then eventually drained through a nasolacrimal duct. Okay, nasolacrimal duct. You can see this nasolacrimal duct. This is how the tears, they drain through a nasolacrimal duct, and then eventually this duct opens into the nasopharynx. So this is how the entire process takes place. So if there is any blockage in it, or any debris into it, any inflammation of the nasolacrimal duct, so there is accumulation of the organisms, there is accumulation of the tear, and then it gets superaddedly infected, and there is a pus formation, and then the person lands up with dacryocystitis. So this is a case of a dacryocystitis with abscess formation. You can see this. This was treated. There is a dacryocystitis with lot of orbital cellulitis. Eventually, patient was given pulsatilla, considering the considering her nature, as well as patient was better by cold application. So she was mild, timid, very, very, a person who would be very, very weak in confidence, would be looking at her husband all the time while we are examining. She was very conscious of the environment, and she was better with cold. So we gave pulsatilla every 2 hourly, and then eventually made 1 every 4 hourly for 20 days. The entire, when I say 20 days, we were evaluating the patient every 5 to 7 days. And then you find that the person is absolutely better with this, with little amount of scar which remained because of there was a superficial wound which had developed. Now in this particular case, if you see, this is again a severe form of dacryocystitis. Here we had used Apis mellifica. With the look of the wound, it was completely erythematous. Patient was saying it is a stitching and a poking kind of a pain, and very sensitive to touch. And we had, and better by eyes. Then we started using Apis mellifica in this particular case. Within 2 to 3 hours, within a single day, there was a softening which was seen within a given point of time. And then on the second day, the pus, this broke and the pus came out. You can see it was drained. This was on the third day. If you can see this. And this was what was seen after the complete recovery at the end of 1 week. If you can see this, this is how the entire pus. So now these things are becomes easier when we know the anatomy, when we know how the disease is going to progress, and what are the things which needs to be kept in mind when we are treating such diseases. So now we have dealt with we have dealt with the cornea. Then we spoke about the nasolacrimal duct. There's a case which is related to the sclera. Sclera is nothing but it is like a coating of the eyeball, and it is on the top covered with a thin film of conjunctiva. So this is how the conjunctiva, you can see this green, purple, this is a conjunctiva, and where is a large white portion behind is the outer portion is the sclera. So conjunctiva is palpebral conjunctiva, which is covering the eyelids. Then there is phonicell conjunctiva, and then there is a bulbar conjunctiva. Bulbar conjunctiva means the part of conjunctiva which is overlying the eyeball. Phonicell is in the fornix, and the one which is covering the eyelids, upper and the lower, is known as the palpebral conjunctiva. Palpebral conjunctiva. So this is a case of vernal keratoconjunctivitis. So this is a case of a young boy, 19 years old boy, which is a person who is suffering from recurrent itching, redness, foreign body sensation, and photophobia in both the eyes. And patient had all the complaint was in the evening, and when he is getting up in the morning, and minimum symptom when he is lying down and is at night when he's sleeping. Patient is better by cold application. And cold fomentation, cold washing. So when I started examining, can you see this like a cobblestone appearance? Normally, when you check your conjunctiva, you never get this. These are huge papillae which are seen on the palpebral conjunctiva, which is seen on both the eyes, and it is classically seen in vernal keratoconjunctivitis. It is classically seen in allergic condition. So this is a case of allergic conjunctivitis with some amount of involvement of the cornea, but primarily it is the involvement of the conjunctiva. So papillae are nothing but they are actually because of the inflammation which is actually getting hypertrophied, and the conjunctival tissues get hypertrophied, and this is known as conjunctival huge papillae. So vernal keratoconjunctivitis is nothing but it is an allergic eye disease which involves begin with the conjunctival affection. Usually it is seen in the young people, and there is a lot of burning, itching, and lot of discomfort, redness, photophobia, inflammation, lacrimation, which is seen. And there are on microscopic examination or on slit lamp examination, you find typical giant papillae which are seen, and there is a lot of hyperemia, and there is some amount of conjunctival inflammation also. So the homeopathic treatment which we gave in this case is pulsatilla 200, which was followed by 1M as a phasic remedy with frequent repetition, and it was followed by, once the acute phase of inflammation was settled down, it was eventually taken over by a constitutional line of treatment, that was natramur, and natramur was given. And you can see this papillae which is before the onset of the treatment. If you see this papillae which is seen by the macroscopically, means even if you invert the eyelid, you can see the papillae. But later on, after the treatment, we had to use a microscope and find out whether there are any papillae remaining. So there are no papillae. The papillae disappeared completely. So this means the patient was completely taken care. Initially, it was very difficult for the patient to move without a protective eyeglasses. He used to constantly wear eyeglasses because he was so sensitive that while driving, while riding, while going out in the garden, while walking on the road, he would slightest amount of dust or any kind of exposure will lead to inflammation, and the huge papillae would develop, and he was suffering for a quite number of years. So up till now, we have covered cornea. We have spoken about nasolacrimal duct. Then we spoke about the conjunctiva. And for us as a homeopathic practitioner, we often get lot number of cases which are presenting as an allergic conjunctivitis. And it is very common, especially young pediatric age group patients. They often come to us and they find solution for this. So this is a rich area where we can, definitely intervene. Then I talk about the sclera. Sclera is just a protective coating of the eye. It's just a tissue which is covering the eyeball, and it is basically given to give the integrity and shape to the eye. Now, this is a patient who had come with a localized inflammation. So how do you differentiate between episcleritis and conjunctivitis? First of all, conjunctivitis will be generalized inflammation of that particular eye. Whereas in episcleritis, there will be localized inflammation, and it will be little like a nodular. It looks as if the node has been raised from the eyeball, and it is very localized. The amount of lacrimation will be much more in conjunctivitis compared to episcleritis. The amount of photophobia will be much more in conjunctivitis compared to a episcleritis. So episcleritis, basically there will be localized discomfort, pain, redness, and some amount of photophobia will be there, and lacrimation. So this is a case of a nodular episcleritis. So it is a benign inflammatory process, and it involves eyes, especially it is seen in women. And if it is not that it is not seen in males, but it is more common in females, and it is like, inflammatory, and this inflammation can be either idiopathic or there can be other causes of this inflammation, especially the autoimmune disorders. You find the patient will come up with episcleritis. So here in this particular case, what we saw is we had used a constitutional approach, and we had given Kalikap 200 followed by 1M, and this was what was the episcleritis completely disappeared. So here the indication of Kalikap was that she is a very, very family oriented person with lot of attachment towards family, lot of anxiety in relation to family, children and husband, and a little amount of fear and startling with the noise which was there in this particular case. And she had hunger aggravation, chilly patient, profuse perspiration. So these all symptoms were collectively pointing towards Kali as a group, and that's why we use Kalikap 200 initially in frequent doses, followed by 1M in frequent doses, and this is what we had seen in this particular case. So we have, if you understand, we have covered with cornea and with the infection spreading into the eye. We spoke about of the conjunctiva. We spoke about the dacryocystitis and nasolacrimal duct involvement. We spoke about the scleral pathology. Now we spoke about neuropathy and extraocular muscles involvement. So this is a very interesting case. It was again an emergency scenario. A 32-year-old female, she had presented with, complaint of ocular palsy, and she is a known chronic alcoholic and substance abuse person. We received a phone call given by the relative that she had inflicted the injury over her left forearm, and this is because she was involved in binge drinking. She was drinking for almost a day, and that's how she landed up with this. So when she presented in the casualty, she was, continuous hiccups, staring look. She was continuously staring at us, puffiness of the lids, and she was trying to hold her breath. She was violent, abusing, very impulsive. She was reproaching self, harming herself, running out of the hospital, and she was refusing the treatment. So this was certain things. And another thing which we saw, she was grasping at other things. This was all what was the observation or the behavior. She had a CLW. She had inflicted that injury because of the binge drinking and all this activity. Her BP was almost 150 by 100. She was tachycardic because of the alcohol influence. The pupils were dilated. So this was the scenario. And what we saw is Massive signs was negative. Massive signs is when we are trying to pinch the ipsilateral side of the eye, and you find there is a change in the size of the pupil. That's a Massive sign. Or you pinch the ipsilateral neck also. So Massive sign was negative. It was found that she was in a catatonic posture, one posture continuously remaining in one posture, catatonic posture in between. She was disoriented, time, place, and person. She was having hesitation cuts all over the body, and there was alcoholic breath, abrupt and incoherent speech, and poor judgment. On further clinical examination, which we found was that she had diplopia. She had developed diplopia, means double vision. This double vision is usually when we are looking at a particular object, we look with both eyes. When we look on the right side, we have a conjugate eyeball movement. When you go on to the left side, we have a conjugate eyeball movement on the left side also. So this is how the eyeballs, they move, right side, left side. Okay, if in case one particular eye is not moving and other eye is moving, then you have two images which is formed on the brain, and that is leading to diplopia. That is leading to diplopia. And she was also complaining of vertigo which was there, and she was better by closing the eyes. There was a lot of photophobia, and what we had seen, there is lateral rotation of the right eye was not possible. If you can see in this particular diagram, if this lady is trying to look on the right side of the field of vision, the left eye is moving inward, but the right eye is not moving laterally. That means there is a paralysis of the right eye. Lateral rectus muscle is not working. Lateral rectus muscle is not working in this particular lady on the right side. Then when the investigations were sent, all the investigations are more or less normal except the urine routine which was showing pus cells. Now here diagnosis is she has actually in acute alcohol intoxication. There is a substance abuse, that is alcoholism, with suicidal attempts, and there is a right lateral rectus palsy which is because of the right abducent nerve which is supplying. So there is a right abducent nerve palsy which is there in this particular patient. So according to the classification, it is acute on pseudochronic with secondary dynamic affection, and there is eventual fully developed symptoms. Acute on pseudochronic. Acute on pseudochronic means there's many a times because of certain substance indulgent, there is a maintaining factor which is now initially to begin with, it is a substance or pseudochronic, and later on it gets converted into a chronic fully miasmatic diseases. So here in the alcohol is the culprit which is to begin with, and eventually patient has manifested into a personality disintegration, suicidal influences, suicidal impulses, and as well as now it has got a physical effect of developing a rectus muscle palsy. This is a small graph which points out that alcohol and suicide has some correlation. Up to 15% of alcoholic people did commit suicide, out of which 80% are male and 20% are female. So if you understand the complete homeopathic concept in this particular case, you have to understand how this lady was pushed into alcohol. So first thing what we should understand this patient is, she had a very pleasant childhood, but she lost her father at a very early age. She was brought up by her elder brother and mother, and she was a very pampered child. Mother got her married at an early age of 15 years, and at a very early age, there was an early marriage, and then she conceived and she did an early motherhood. And husband left her when her daughter was born. So she had a pleasant childhood. Eventually, she was married early. Eventually, she became an early mother, and then later on, the husband left her because as soon as she gave birth to a female child. This is the reason why she landed up with alcoholism, because there was a lot of grief in her life. And her behavioral symptoms came into picture when she started becoming abusive. She started harming herself, and she started, had a multiple episode of suicidal attempts. So overall, she is a irritable, violent, but reserved individual. And because of this early marriage and early separation, or early separation from the husband is not there. And right now she is almost in her 35s. So there is a long period which is led into celibacy. There's a lot of sexual suppression which had dealt, and which patient's relative also had observed and informed in an indirect manner. And all these things coming into coming together, like alcoholism, grief, celibacy, multiple suicidal attempts in form of hesitation cuts which were seen on her forearm. Previous cut scars were also there. And then eventually landing up with a right abductor nerve palsy with diplopia and vertigo. She had dreams of pursued by enemies. She had dreams of being pursued by enemies. And as a defenses, she had a lot of suppression of her emotions. She had gone through a lot. She is, since reserved by nature, she is not expressing to other people, because there's a lot of suppression and repression in forms of reflection in the dreams, and somatization in form of the paralysis which develop. She has craving for alcohol, spices, and she's a chilly person. So eventually, if you understand, it's a psychosyphilitic dimension. Here we understand the psychodynamics of the person. The contributors in our life situation is early marriage, early departure, early mother, or early separation, early motherhood, missing partner, early responsibility, and this eventually there is a celibacy. So all this kind of environment, all this kind of, she's all alone, single mother, taking care of all these things, no help, there's no help, no support, there's a compulsive anxiety which develops. Compulsive anxiety and some phases of depression and anxiety led her towards alcohol. There was an indulgence into a substance, alcohol abuse, and this is a reflection, according to the Freudian theory, stage of oral fixation, where the person is trying to calm down the compulsive anxiety by getting indulgent into a different form of addiction. Either it is smoking, or it is alcohol, or it is getting into some other form of substance abuses. And if you understand her ego defenses, the defense mechanism, there is a lot of anxiety. One hand, she is taking care of this anxiety by getting diverted towards alcohol. Other hand, this anxiety is getting repressed into her subconscious, in form of paranoid dreams, where she gets this dream that somebody is pursuing her, and there's an enemy and somebody is pursuing and somebody is trying to attack her or somebody is trying to harm her. So this kind of repression is seen in this particular thing. Secondly, what we see is there is a anger which is introjected in form of damaging oneself. So there is a different, one hand there is an anxiety, one hand there is an unexpressed anger which is introjecting, or it is moving inward and harming oneself, damaging oneself. Other hand, this anxiety is getting reflected to the subconscious. So that is what I had understood about this patient. Now, if you understand the interpretation of the dreams, her dreams are actually nothing but it's a repressed reality or the feelings which is getting reflected into the dreams. Here, the dream is being pursued by enemy or by uh, uh, by a threat. So enemies is nothing but it's a symbolic representation of the threat. And threat, if you understand, the threat is nothing but her reality's husband who has abandoned her and she is running to protect her. So that is what is the reflection of the dream. If we connect the life conscious environment of this person and her subconscious. So if you connect, this is what is the understanding about. So this is contrary to her conduct. One hand she is dreaming of threat and trying to survive, the other hand she is harming her own self. So considering this contrary, should we give agnesia? That was what we had come. But what we understand, the background of alcoholism, celibacy, grief, dreams of being pursued by enemy, vertigo and paralysis of eye muscles. There is a right abducent nerve paralysis. The remedy which came up was Conam. So Conam was a remedy which we chose in this particular case because it is covering all the important symptoms of the case. And if you understand the dreams, it is also covered by Conam. And even the contrary conduct, reality, she's scared. In subconscious, she's scared. And reality, what she's doing is she's anxious but she's harming her own self. So considering all these differential drugs, if you read, we are focusing on the Conam per se, the drunkenness, anxious dreams, and the absence of action of the muscle, which is supplying the fourth and the sixth. So abducent nerve is nothing but it's a sixth nerve. So if you see other material also, dreams of danger is given in Clark's Materia Medica, and paralysis of the muscles of the eye is given in all the books and the diplopia. So I'll show you the response of the Conam. We started with Conam 200. This is at the start of the treatment. We had given frequently 1 hourly for 2 days. Then after 2 days, there is little registration. There is very little minimum change, which is very difficult to be noticed. Another 2 days, and now if you see, this is what is at the end of 8 days. If you can see the eye movement. So this is what was seen. At the end of 8 to 10 days, this is what she is able to move her right eye completely. Now, in this particular case, modern medicine people would have given intravenous steroids with high doses of multivitamins and B12 injections and all, so that they can reduce the inflammatory changes which has developed. Or so that is why the steroid is intervened, so that the muscle function can be restored. So this is the case which was treated with Conam. So I think there are many more cases. We will conclude the session here, and let us have some question answer session so that we can solve certain doubts. Yeah, Dr. Twinta.
Yes, sir. Thank you so much, sir, for the lovely cases. We have some questions on the chat box. First one is retinopathy manageable?
Yeah. The first question, yeah. So for first, we have to understand what is the reason for this retinopathy. There are multiple reasons for this retinopathy. There are certain retinopathies which is basically because of the sedentary lifestyle disorders like hypertension, diabetes. So these are major. Certain retinopathies can be like, uh, retinitis pigmentosa. It's something, but it is a genetic, it is the person is born with that. The person will have certain retinopathies can be because of deficiencies which will. So it all depends, or some retinopathy can be because of the autoimmune immune phenomena. So first and foremost is diagnosing what kind of retinopathy is there. And if it is diabetic or hypertensive retinopathy, definitely we have so many drugs which can limit these retinopathies. Basically, first more important thing is to control the blood pressure and diabetes. So any medicine which is targeted towards that, and along with that, there are certain sector remedies which can be used for the eye problem as such. The main retinopathy drugs which we can use is I found is Crotalis, especially in diabetic patients, diabetic retinopathy, advanced retinopathy. This is one drug which I have used with very, very frequently. Then phosphorus is a very good drug. Phosphorus is a very good drug. Then naphthalinum. Naphthalinum is another good drug for, very, very progressive kind of a diabetic retinopathy or something. And all the other retinopathies which are related to autoimmune phenomena. So the approach has to be constitutional drug. It is always important to take the constitutional history, and along with that, you take the sector history of the eye. So there will be different forms of drugs which will come, but constitutional drug, it should not be ignored. And eventually maybe, we have to give infrequent repetition of intercurrent drugs.
Thank you, sir. We have our next question. Can we prevent fungal infection in iron invasion?
In iron invasion, what do you mean by iron invasion? Infusion you are saying, or invasion? Means iron particles going into the eye, that if I have understood right. So if there is an injury, injury is something which is beyond our control. It is an unprecedented or unpredicted event. So once the barrier is ruptured, any infection can go into the eye. So we cannot prevent it. What we can do is we can take care of that foreign body. We remove that foreign body, and secondly, whatever the inflammation and infective changes which are setting in the eye, we can use the medicines to treat them. So that is what we can do.
How can we help patient of glaucoma?
Yeah, this is a very common disease which we are finding. Yesterday only I got one patient. So for foremost thing in cases of glaucoma is identifying if it is a closed angle glaucoma or an open angle glaucoma. If it's a closed angle glaucoma, please don't treat. Tell the ophthalmologist to make a iridectomy, do a iridectomy, make a hole in the iris with the help of the laser, so that the pathway is open, and then you don't need to treat it, because the pathway is open. The aqueous humor will automatically drain, the pressure will reduce. But if it is an open angle glaucoma where nobody knows what is the cause for it, predominantly it is idiopathic in origin, then it is you can treat this patient by giving homeopathic line of treatment. Again, I will always suggest take up the constitutional drug, but there are other drugs like, as I have said, there is phosphorus is the drug, belladonna is a drug, because there are certain symptoms which is projected in form of the glaucoma. Symptomatology is headache, photophobia, throbbing headache, patient is not able to bear the light. Then spigelia is a drug. Physostigma is a good drug. Physostigma is a good drug. Osmium is a very good drug. So everything depends on the symptomatology which develops. Comocladia is a good drug. So, so these are various drugs which comes. It all depends on what kind of symptomatology. So I have mentioned about the classification. First is, if it is a closed angle, please don't treat. Let the surgical intervention happen so that the patient gets more benefited. See, eye is such an organ where we have to be very clear whether we have to take up this case or you allow the modern medicine or ophthalmologist to intervene and relieve the person, because any pressure mounting in the eye will kill the optic nerve. Patient will go into optic atrophy. Then another form of glaucoma is secondary glaucoma, as what we were trying to discuss in this case of the injury. There was an injury in the cornea, and then the infection is going on, and eventually patient may go into a secondary glaucoma. So glaucoma, which is because of other diseases of the eye or other systemic illnesses, and then the patient is having glaucoma, these particular diseases also can be treated well with homeopathic line of treatment.
How can we treat bacterial follicular conjunctivitis?
Conjunctivitis, whether it is bacterial, whether it is viral, whether it is fungal, any origin, should be treated on the same principles of homeopathy by taking the case and following Bonning-Hossen's approach. What I always tell all my students is, whenever patient is in acute distress or any kind of a problem, they often remember the modalities very well. They know how the problem started, they know how it increased and how it is reduced. So it is basically very important to formulate the totality and give the drug. So that's how you can, treat the person. So organism which is producing is of no significance. It is only for a medical prognosis, but for totality formation, that may not help us. But what are the manifestation? That is main for us to form the totality and give the medicine.
Scope of homeopathy in macular degeneration.
Yes. So macular degeneration, again, it is either early onset macular degeneration or it is a age related macular degeneration. So if it is a senile macular degeneration, so it eventually comes in the later part of the life, where patient is also not very much interested in taking the treatment. If it starts early, that is a time where we can intervene very beautifully on drugs which is involving the retina per se, and even another thing is the right constitutional drug, because I have seen that macula, the deep acting remedies and constitutional drugs act better than a specific drugs, like the involving the retina, like there is a drug called acetalidum, which is mainly for the contracted optic field, and the disc becomes pale for the optic atrophy. So this is a drug which is given in the later stages. Before that, we can use constitutional drugs. Many a time it is seen that in this macular degeneration, all the syphilitic drugs may often come up, or the metal drugs which comes up. The metal group comes up very commonly in these cases. So, and as suggested, that what is resulting into maculopathy is also important. If there are any toxins which are patient is having any kind of habits like alcohol, smoking, any form of drug, then the simple remedy like Nux vomica can come up for the retinal involvement or the maculopathy.
What about eye surgery for myopia, and which remedy can help in case of eye dryness after laser surgery?
Any surgical interventions, Staphylococcus aureus should not be forgotten. And other important is hemamylase. Any surgical intervention, Staphylococcus aureus and hemamylase, these are two drugs which comes very commonly. And many a times, if there is a dryness, we need to find out what is the reason for the dryness, whether it is a local reason or there is any other autoimmune disorders in the body like Sjogren's syndrome. We should not forget what is Sjogren's syndrome. And secondly, we should not forget any kind of thyroiditis in the body. So these are certain diseases, because autoimmune diseases can also produce dryness. And if it is plain, there is no other disorder, then lubricating the eye drop along with the right indicated remedy can be used in this particular cases. The remedies like sulfur and euphrasia can also help in dry eye. The remedies like euphrasia and sulfur.
Differentiation and management of acute and chronic bacterial or viral infection.
It's a very broad question, but again, the approach is acute bacterial or viral infection of the eye, again the approach is it depends which tissue of the eye it is got involved and what is the presentation. It all depends on that. And accordingly, we formulate the totality. See, I per se, the major difficulty is in the diagnosis. Once you get the diagnosis, finding the remedy is not difficult. First thing is to identify the disease is the most important thing. And eventually the finding a remedy will not be so difficult once you get the diagnosis, because you know what is common to the disease and what is characteristic to the disease, and you will pick up the same symptoms.
Scope of homeopathy in retinal detachment and diabetic retinopathy.
Diabetic retinopathy per se, if it is a proliferative diabetic retinopathy, and if it is eventually leading to a lot of fibrotic areas in the eye, what we can do and then see basically what happens in proliferative diabetic retinopathy is that there is lot of vessels which are fragile. They are they are growing into the retina, and they are so fragile that even the movement of the eye they can break, or just a sneezing or just a coughing they can break. And once there is a blood in the vitreous, they forms a fibrous strand, and these fibrous strands will start contracting and pulling the retina, and it detaches the retina. So what we need to do in this situation is first understand the process. We have to first see to it that this fibrotic areas needs to be diluted. So the remedies like calcarea fluor in lower potency, like 3C, 6C, or thiocinimum in 3x, 6x potency can be used to cut down the fibrosis. Secondly, we don't allow the new vessels to form. So then the remedies like, phosphorus or crotalis can be of, or sickle core. These are certain, or hemamylase. These are certain drugs, or lacases. These are certain drugs which can be helpful in reducing the vascular formation. And then the third is definitely we have to use the constitutional drug to basically control the diabetic state of this person. So we have to juggle between all these drugs. Maybe many a times there will be a situation where we may have to use multiple forces at one time, or we have to use a particular force and then follow it with the other remedy. So that is what is seen practically.
Any experience with LM potencies?
Yeah, I had a case of retinitis pigmentosa which I was about to present. I had used Lyco 0/1 in that particular person. His vision, he was a case of retinitis pigmentosa, and along with that he had night blindness. Night blindness is actually a typical symptom of retinitis pigmentosa. And if you read Norton's eye diseases, lycopodium is one drug where he has written that there are multiple eye symptom in lycopodium, and another drug is aurum metallicum. There's a lot of retinal symptoms given in lyco and aurum metallicum. Considering the hemianopias, can see only lower half, cannot see the upper half. So, like aurum can only see the right side, left side, one side. These all hemianopia symptoms are being mentioned very, very clearly in lycopodium and aurum metallicum. So we can use these drugs. And another important thing, 0/1 potency can be used, especially if it is to be repeated very frequently, and if the person is very sensitive, and there are chances that the patient may aggravate. So we can give in 0/1 potency. Right now, I am treating a case of a congenital rubella with a corneal opacity. So she has all the constitutional symptoms along with a eye symptom. So there is little clearing of the corneal opacity, and her weight has started increasing. When she reported to us, she came with 10 kg. Now she is already almost 15 kg, and there is a complete retardation of the growth because of the maternal placental infection. Maternal, when the child was in the womb, there was a maternal rubella which was transmitted through placenta, and child was born with a congenital rubella.
So there's a query about a case, retinal hole in inferior part of peripheral retina in sulfur constitution with myopia, complaints of floaters, family history of retinal degeneration, any scope in homeopathy.
See, now patient is having a very high myopia. In high myopia, the eyeball is overstretched, because of which there is a stretching of the retina and there is a retinal thinning. So it's like a, if it's a bed sheet and you stretch it and it will tear off. So basically the first objective is to somehow give a remedy which will take care of the overstretching phenomena. That is first objective. So in high myopia, the drugs which are usually we can think of is physostigma, where the numbers are increasing. Second, you can use Ruta, Natrium. These are certain drugs which are basically targeted through myopia. But nevertheless, there is no substitute for the constitutional drug. We have to first see to it that the constitutional takes care of this particular phenomenon. Second, if there is a retinal hole developing and slowly there is a percolation of a fluid below the hole, and that lifts the retina, then in such situation, gelsemium is a drug which can be given. Because subretinal fluid collection, gelsemium is a very good drug. You can read from Borik's Materia Medica and Clark's Materia Medica. And it has been mentioned in a lot of places in the Materia Medica. So in that phase, you can use gelsemium in a lower potency, 6 or 30 potency, and frequent repetition. So that can be handled, in the due process, and eventually you may have to use an intercurrent in this case intermittently. So that, and there are certain hereditary tendency where we find that the entire family line is high myopic. So this is what is usually seen, because somewhere the weak eye concept flows through the entire family or the family tree. Hello?
Case.
Yeah.
Does alcoholic patient has GI disturbances? Was it grief or suppressed anger in the last case? These two questions are about the last case.
Okay. So she did not have predominant GI symptom. It was not a brief spell. It is eventually over a period of her 15 to 17 years of her life, where she was a single mother. You imagine a lady gets married at 15. It was a child marriage, basically. And it was done in the rural part of India, in some village where she was married. And she was, within no time, she was pregnant. And at 16th year, she got a mother, and she has to take care of that child, doing meager jobs. And she's, running the house. And this is what was there. And this was basically anxiety and anger and, low phase and solitude and with, suppressed sexual desire. So all this combination was acting in that particular case, and that's how we came to a CONAM. Per se, if you see, looking at the paralysis part, you'll think, okay, you could CONAM. But when you see this, CONAM was even covering our constitutional aspect and the entire evolution of the drug picture, then it gives you a better understanding how it covers to the deep end, till the level of subconscious.
Can dry eyes be cured in spite of the patient having to work in front of the laptop?
Yes, dry eye because of certain kind of occupational hazard can be cured, but it is difficult if it person goes into keratosiska. There's some condition known as keratosiska, means there is complete death of the tear glands or the conjunctival cells, which produces some amount of lubricant. Certain cells are there in the goblet cells, are the cells of the conjunctiva, which forms the secretion. So in autoimmune disorders, or like how we get xerostomia in Sjogren's syndrome, similarly they may have dry eye and dry mouth. So these disorders, we may have to put a lubricating eye drop. So the cure in such cases will depend how controlled is the constitutional disease. If the Sjogren's syndrome is under control, Sjogren's syndrome's inflammatory process is under control, then eventually these symptoms will also start improving.
There's a query about snow vision. In examination, there is nothing found. The patient is born with this.
So basically it is idiopathic in origin. So we when there is no pathology seen in this, then we can directly start the treatment by giving a intercurrent as sifilinum and trying to understand the constitutional drug and prescribe that. Because I have seen that if you get a right constitutional and give it, we may be able to help this person. We will be able to help this person. These are basically, the perceptory or disorder of the pigments of the retina. There is a error and the confusion which is there in the relaying of the light impulses to the brain. So this is something to do with that. If you open Borix materia medica, the perception of light is lost. There is a remedy, one remedy which is mentioned in the repertory section of Borix materia medica, that is Califos. So we can use Califos in this drug if there is we can see how well the person responds to this. I have heard about snow vision, but I have not yet treated a patient of snow vision.
Scope in retinitis pigmentosa and pterygium.
Pterygium and I have already mentioned retinitis pigmentosa. It's an autoimmune. There is no cure in it. Only thing is, it may be coupled with some kind of retinal detachments and all. Then it becomes a problem. Then they do a surgical intervention. For retinitis pigmentosa, we have drugs. Especially, I mentioned that lycopodium has a lot of symptoms of retinitis pigmentosa and pigmentary disorders of the retina. And in that case, lycopodium is used, and it has given a lot of result in couple of cases. I have seen around 4 to 5 cases of retinitis pigmentosa where I had used lycopodium and it had helped. And other important thing, since it has got night blindness also, many a time these patients are supplemented with vitamin A supplements also. So we should give a lot of vitamin A so that if there is any deficiency component, that can be corrected, And even in dry eye, if there is any vitamin A, we should supplement it, because many a times these occult deficiencies will not be seen. Usually in India, we end up doing vitamin B12 and D3 investigations very common. We do not check vitamin A very frequently. So that's why any dry eye, when you find, or any kind of dryness that the patient is complaining, we should supplement the person with vitamin A supplements.
Actually, we are already overshooting the time. We'll be just taking the questions that are currently on the chat box. If there are any other questions, apart from this, we will encourage you to kindly contact us and we will drop in your queries with your answers. Right now, we'll continue with our question answer session. Can we improve vision in young children with myopia?
Yes, nowadays there is a huge craze of people at the young age demanding LASIK. So I will tell you one thing: if a child is born with myopia, first is identifying myopia at the right age is very important. Second, the eye of the child is having an immense power to accommodate. So many a times the person, one normal eye will take over the function of the abnormal eye, and you will not come to know till the time the child becomes vocal and he is able to express. So, initial 4-5 years, you miss that the child's vision is, if one eye is lazy, the other eye will take over. And this eye undergoes, initially to begin with, it is myopia. Then this eye becomes a lazy eye and it is known as amblyopia. It goes into amblyopic phase. So identifying at right age and correcting it with the spectacles is very important. And then along with that, you start homeopathy so that the number doesn't increase. Here again, constitutional approach is very important. And there are certain drugs which is specific for myopia, as I earlier also had mentioned, that higher myopic patients where physostigma is one of the drugs which really helps. Natrium is another drug which helps. Then if there is an accommodation issue coming, then you can use gelsemium also with this. And Ruta is another drug where there is a lot of eye pain and all. So it has to be a combination of the constitutional, and there will be a brief phase where we may have to give a certain selected remedies, and eventually it will be there will be a spectacle which needs to be given. If there is a myopia, there may be underlying deficiencies also which needs to be corrected. And definitely the exercises are very important. The eye exercises are very important. The accommodation exercises, the eyeball movement exercises, all these exercises will strengthen the muscles and which will take over some amount of accommodative function of the eye, and that will help us to strain less. If the straining is less, the number will not increase at a faster pace.
Scope in disc edema and amblyopia.
Yeah, amblyopia, again, I have mentioned amblyopia, most commonest cause of amblyopia is either idiopathic, or the other thing is because of the toxins like alcohol, or there are amblyopias because of, transient heavy bleeding. If a lady is bleeding heavily and there is a lot of blood loss, eventually, she loses her vision. So all these things are very common. So remedies, understanding the cause, you can give the remedies.
So there's a question. Post cataract operation, allopathic drops are suggested, and doctors threaten that unless the drops are used, the sight will be lost. What is the acute homeopathic medicine for such cases?
See, basically, when the cataract surgery is performed, the person who's operating knows the best, because he knows what part of the eye he has touched. So we have to listen to that person. But eventually, what they try to do is they give you a combination of an antibiotic and a steroid. Many a time when you cut the eye, there is an inflammatory process which is taking over the outer part of the eye, but there may be some inflammatory process because we have entered the eye related to iris, then there can be an inflammation. So what happens is, if there is inflammation, there are chances that that lens may get displaced, or there can be swelling over the lens where the vision may get compromised. That's why they give you a combination of antibiotic and steroid. So in this situation, the remedies what we used to use in the rural setup, we used to give a combination of arnica and staphysagria, because there is a cut and there is a hemorrhage, there is a congestion. So considering these 2-3 factors, we used to give combination of arnica and staphysagria, which was given very, very, very rapidly. Means we would repeat that particular drug every half hourly or 1 hourly also, because if we don't control it at an initial stage, the inflammation, if it starts, then there is no option left. So arnica and staphysagria is the commonest drug which we use.
Scope in astigmatism and recurrent eye problem.
Astigmatism, again, there are a lot of remedies like lilium tig, gelsemium. Then there are other drugs which come up, which is training astigmatism, is also there in physostigma. Then other drugs are also there for astigmatism. Best is the constitutional approach which we use with the corrective cylindrical numbers, which are important. So see, anytime when the patient comes to you, don't say that you don't wear glasses and I will give you the medicine. In fact, I feel we should give the patient the glasses, and along with that, you continue the medicine. Your objective should be that the number should not keep on fluctuating, or it should not keep on increasing. First thing. And the second, what was the second question? Recurrent stye. Stye is the most commonest ophthalmic disorder which comes to our clinic. So we see it very frequently. Like example, if there is a repeated stye, then the remedies which come up is staphysagria, as you all know. Then Apis mellifica is another drug. Then pulsatilla is another drug. Then there is a drug, I forgot the name of that drug. It starts with P. So I'll just refer and let you know. Yes, Platanus occidentalis. Platanus occidentalis is a drug which is very frequently used in tarsal tumors, more of when there is a chronic fibrotic things which is forming, and especially chalazion. And calcarea floor is another drug which is used for recurrent chalazions. So this can be easily managed. So we have to counsel the patient that this is a recurrent phenomena. Even if you go into a surgical intervention, it is no guarantee that it won't come back. So you have to correct the tendencies. This is how I convince my patient.
Can we stop the progress of cataract with cineraria eye drops?
Yes, cineraria eye drops, clinically it has been very helpful. And in fact, with cineraria, we can give an oral potency of cineraria also. Another drugs which helps in cataract arrest is conium and causticum. and Ratania. So more of Conium and Causticum, which is of use, and Cineraria eye drops can be used along with the oral potency also. Cineraria, oral potencies can also, in a lower potency, we can use. But if it is a complicated cataract, I advise the patient you remove it, because see, the person has already suffered with some inflammation in the eye, and it is already a very, very dense cataract. It is better you remove so that he gets a sigh of relief and he can see. Vision is very important, It is equivalent to life. Vision is equivalent to life. That is what I feel.
Experience in blepharitis and cataract.
Cataract, if it is in the center of the vision, I tell patient you remove the cataract and be happy. Secondly, I also see the age at which the cataract is developing. If it is in an elderly age group, there is no point in delaying the operation, because the patient will come to a zone where he will not be fit for surgery. Then it is very difficult to operate the person. So we have to understand first that thing. Secondly, I had already mentioned that we give, if there is any inflammation in the eye which is leading to opacification, then you treat that inflammation. So you have to, whether it is a senile cataract or it is because of secondary to some other inflammation, that we have to first judge, and accordingly you take the steps. So this is what, and I had mentioned that Conium, Causticum, Calcarea floor, all these remedies, they help in arresting the growth of the cataract. Then Cinega is also very, very important drug, especially posterior capsular opacification. Cinega is a good drug. I used to use Cinega in post-operative cataract patient who used to develop haziness after a cataract operation. They used to develop haziness of the capsule because of the inflammation. So then Cinega in 30 potency was of very use.
Dr. Ashok Madan, if you have any question, you can unmute yourself and kindly ask Dr. Rakesh.
Thank you very much. This is Ashok.
Hello,
Dr.
sir.
Gupta, good afternoon. I have two questions. Please guide me, and I need your real, very sincere opinions. I have two patients. First, I will talk about one new patient that he came actually for the polyps and especially anxiety too much for the narrow places. And he told about this operation of left eye with strabism divergent, means tending to the outer side of the left eye. After that, he turned his neck, always keeping on the right side after the operations, and he have to turn always the neck looking by the angles, having very difficulties anyway. Whatever, it was already 2 years when he had this operation. Now this moment he was given that I have to tell you that dose of Aconitum 1M, it helped with the other situation of the anxiety. But the question to you remains about this situation of the operation that he had it for the strabism, and he's standing towards looking in the angles. Then I will make the second, or I should continue telling the second.
No, we'll answer this first. So
Okay.
what was the medicine you prescribed, sir?
Just Aconitum this moment, because it was just for 3 weeks. I had a very long interview because I was wanting, because from the childhood is suffering for the anxiety. So it took me a long time to go through to start with Aconitum. That may help also any of the fright according, but other side, the operation. Please do that.
So the remedies for squint, primarily with if the person is tilting one side and looking so that he gets a clear image on the retina, the remedies which comes up is Cicuta and strabismus, stramonium. Cicuta and stramonium, these are the drugs which come up. Very commonly we have found in squints. So basically there is another drug like cyclamen which comes up. But I think when the tilting of the neck and all, Cicuta, you should read from the literature, Clark's Materia Medica. If the symptoms match, you can try out with Cicuta. And the another drug which comes up is considering the muscle. Basically, the problem is with the muscles of the eyeball.
Muscle.
Yeah.
Yes.
So then gelsemium is another drug which comes up.
Okay.
So I had a case of a female. She would just come and sit in front of me. That she said that I have no strength in the body, and sometimes I look at the person, I feel I am seeing double. And I know my people say that my eye is just squinting away. So I had used gelsemium in her with 200 potency to begin with, and then eventually 1M. 1M was, so the remedies which I suggest you will have to match with your case. First is gelsemium, cicuta, and stramonium. These are 3 drugs which you look into.
Okay, that's fantastic. Thank you very much, really. And the second case is about male of 42 years old. From about 10 years, he started to have the myopia. And after 5 years, he started to have this pressure, ocular pressure went up to 30, too much.
Too much.
Very
high.
Yeah, very high. He lost of the left side, the left eyesight is just 20%. And then they operated. He's in England. So secondly, they operated also the right side where the pressure was too much, about 30, 35, like this. I was able to help him for his anxiety, of course, because he was very afraid about the situations that he will lose his eyesight. He already lost of left side about 80%. So now, before 1 year, when he had the second of right eye operation, that the eyesight tends to go down and went down for 30 to 40%. Before he was having 9-10, now it is 6-10. Pressure came down to 20, 21, 22 for the both side. He was given about beta blockers, this and that, everything. And after this operation, he started also the cataract, which is not too much at this moment. So I advise even this drop, what we were talking about, this scenario. And he was given arnica for one time, but I was very much careful about this thing. So tendency to reduce this eyesight, pressure is better, and myopic -14. One side is -11. So there's not easy patient, it's not easy patient. Please guide me something.
Okay. So basically, it is a complex case. The reason for high pressure, any other reason is there for the high pressure? Only myopia, they are attributing to myopia only.
No other reason. He didn't tell anything. No accident. It happened like this,
Right.
Started up. I have gone through much of the information, but in certain senses, he seems to be very secretive because I have known after 6 months of the interrogations that he didn't like to tell that he's having also these male problems of erections, everything, certain problems that he can, infertility in a very brief things. After 6 months, just imagine, he was hiding and hiding. So this type of patient having complication with eyes, and he's very afraid, always very fearful, anxiety of this thing, photophobia, sorry that I forgot to. Photophobia came after the last operation.
Okay. So basically for ever increasing pressure, the drugs which we can think of is, one is considering the anxiety and IOP raised, aconite itself can be used in a frequent repetition. If there is pain with increased tension, then belladonna can be used. And if there is a visual compromise which is happening, then the phosphorus can be used, because phosphorus is basically has a good action on the nerves.
Yes.
And so phosphorus can be used. Another drug which can be used is osmium. Osmium is another drug for the raised intraocular pressure. So again, you have to use these drugs at different stages, depending on which stage is predominant.
All right.
So
but you see, as you talked about phosphorus, he's too much. In the evening time, he will reach home. He must bring this rasmalai, sorry, that he have to eat maybe 200, 300 grams of rasmalai, you know.
Right.
Sweets are 3 plus, you can say, even 4 plus.
Yeah, right. So accordingly, you can take the action because you'll have to formulate the totality and see
Okay.
what is covering his basic symptoms, you know.
All right. But we can give him one dose of maybe 1 m aconitum or lesser.
No, you start him accurate on 30 potency.
Okay.
30, you give 30 QDS.
Okay.
Give it repeatedly
Repeat.
because we have to target the tissue.
Okay.
Changes have already taken.
That will be fantastic. Could I ask later to the office of Dr. Prajakta or Dr.
Yeah.
Shah that I can have your email so that maybe you can help me
We
more?
can discuss. Yeah, that will be my pleasure.
My Dr. Gupta, thank you very much, really.
So where do you practice?
I'm here in Switzerland.
Very good. Okay, very good. You're doing good job. Very difficult.
Thank you very much.
Practicing.
Thank you. Hope to listen through the emails and regards
Thank
to
you, sir.
from my side. Namaskar.
Okay, namaste, sir.
Thank you, Dr. Gupta.
Contact us on the number that is on the chat box. We will address your questions that you have any further.
Thank you very much, Doctor. Thank you.
Thank you so much, Dr. Rakesh Gupta, sir. It was so good. It was such an informative session. I think we have overshooted the time, but we still have participants waiting to listen to your, valuable comments on each and every question. You took it so rapidly and you addressed all the questions that were on the chat box. Thank you so much. The session on the eye disease was completely an eye opener for all of us. We got to see even emergency cases. So thank you so much, sir, for being a part of Homeopathic Musings. And we look forward to your future sessions as well. I thank all the participants who have joined us, and we look forward to your participation next time as well. Thank you so much, sir.
Thank you. Thanks a lot.
Thank you again, Dr. Gupta. Namaste.
Thank you, sir. Thank you.
We end our session right here. Thank you all.